given haven't given the crab precipitate, we haven't given everything else. Now we need to give Novo-7, which is an activated 7A, as you know, but patient is still bleeding. So can anyone say that you have given all the products in a major hemorrhage patient is bleeding and you are giving lots of blood transfusions, say you have given 15 units of blood, patient is still bleeding in cardiac theater, for example. What is missing? Can anyone say why the patient is bleeding? You're trying to ligate what is missing, what is leaking, and patient is still bleeding, and we giving lots of blood product like fresh frozen plasma, vitamin K, Novo-7. Why the patient is bleeding, do you think? Platelets? You're giving platelets as well. You see multiple platelets being given, and platelets is currently 120 or 150, which is normal. Patient is still bleeding, and you have done an PTT and PT in the lab. It's very prolonged. It's a PTT is 100, and PT is about 50. Thrombin time is probably 65. Patient is still bleeding. So you have diluted that. Is excellent. Is that so? How do you generate a fibrin clot? What do you need? You generate thrombin by giving all the possible product, as you said, extrinsic, intrinsic, and you're giving your platelets, you're giving tranexamic acid, you're giving fresh frozen plasma. But if you do not have fibrinogen concentrate, you're not going to get the clot, are you? Fibrinogen, they converted by thrombin to fibrin clot. So you need to produce or give lots of fibrinogen. You are absolutely right, because you're giving everything else, but patient does not have any fibrinogen. So you need to give fibrinogen. Now we have fibrinogen concentrate available. I don't know whether we have it here, but typically what we advocate you to give lots of cryoprecipitate. Fresh frozen plasma will have some fibrinogen, but at lesser extent. So you need to give lots of cryoprecipitate for this patient. And this is what is missing. It happens all over the world. The last week I got a call from one of the cardiac hospital, a junior anesthetist said, sir, we have given lots of products. We need to get approval for Novo-7. The patient is still bleeding. What is your latest clotting? It's still prolonged. What's the fibrinogen? We haven't checked it. I can reassure you it's very, very low, and they checked it, and retrospectively it was less than 0.5. And that's why patient is bleeding. Within this period of time, we have given fibrinogen concentrated, patient stop bleeding within an hour. So that's very important to remember. No fibrinogen, no clot, that's the message. This is the major hemorrhage protocol, get alerted in the hospital, outside the hospital. I think it's quite busy, you can't see it, but it is available on the internet and download it. And that specifically tells you what are the component and the factors you should be using in a time-dependent manner. That's very important. And you can download it from anywhere. This is a typical scenario happens in our world, in the United Kingdom, most of the European countries. We struggled a lot. When I was a registrar, we didn't manage to get the blood component flying to the site because of the regulation was quite strict. So ambulance are able to take the blood component to the site and you see what happens. No traffic jump here. You see when a trauma situation or critically unwell patient on the street, whatever. Pre-hospital care, rapid response team will go and resuscitate the patient, ventilate, initiate all the fluid appropriate, and they will be taken to, this is from the Royal London. I think we have here a consultant surgeon who worked in Royal London Hospital. I don't think he's here today. The colorectal.
Dr. Sadiq.
Yes, Dr. Sadiq. So he was in this hospital. So with this patient is the hemoglobin 50, full platelet count 260, white cell normal, full clotting screen is normal. The fibrinogen was baseline normal, urea electrolytes normal, bones profile was normal. So you continue to give tranexamic acid, 16 units of blood, 16 FFP, 3 pools of platelets, because this comes with the trauma pack automatically. One thing to remember, I get asked from our trainees or doctors in the UK, then you say trauma pack. So do you keep within the trauma pack, the fresh frozen plasma and cryoprecipitate? No, because they are kept in the fridge. So this is within it, but that will take at least 30 minutes to thaw it. But when the trauma call initiate, hospital gets alerted that trauma landing 5 minutes, 10 minutes, 15 minutes. So that will be told for you automatically. That's very important, the coagulation, the whole cascade, as we all remember. Just one thing to remember is no fibrinogen, no clot. You can give all the products possible. Fibrinogen is very important to produce the fibrin clot. That's important. So you can see here the 1 gram fibrinogen concentrate was given and the patient's APTT is coming down, bleeding now stopped. Patient day 20 was alive. So you see the dramatic improvement following the massive hemorrhage protocol initiated and patient received multiple transfusions, including fibrinogen concentrate. We didn't have it before, but now it's available. I don't know, sir, do you have fibrinogen concentrate here?
No.
Not yet. But I think that will be quite easily available within a short period of time. So if you have a massive GI bleeding, which happened in city of Dhaka not long ago, a patient was 70 years old, admitted with the hematemesis and melena, inpatient urgent blood transfusion initiated, OGD showed severe esophageal varices, medical therapy started, as you know, as per protocol, ongoing bleeding, hemodynamically unstable patient. The patient was taken to the ICU in a private hospital. The patient was on rivaroxaban. So unfortunately, at that time, the andexanet alpha was not even available in the UK, but now we have it. In this particular patient, the prothrombin complex concentrate were used because the patient was on rivaroxaban, and that partially reversed the rivaroxaban effect as well. Some hospitals still using prothrombin complex concentrate. But because of the andexanet alpha availability, which will go to the circulation and bind to the molecules of the rivaroxaban and inactivate it within seconds. So that's usually a initial IV dose and that's subcutaneous 24 hours. Andexanet alpha is stored. So patients you see very, very anemic hemoglobin 45 to 4.5, platelet 56. INR is very high because of the patient has got liver failure. Liver cirrhosis, PTT was prolonged, fibrinogen was 1. One thing to remember that there are 2 ways of, Dr. Rumi will tell us here, there are 2 ways of testing the fibrinogen. One is commonly used a quantitative amount of the fibrinogen, but if you want a qualitative fibrinogen, it's a closed method which we use to see the functionality of the fibrinogen. Sometimes you might have an acute phase reactant, as you know, like CRP. Fibrinogen is an acute phase reactant. So actually, probably a fibrinogen 7, the functionality is not good, and that's why, despite normal fibrinogen, APTT and PT is prolonged. So in that case, we do the closed fibrinogen method to assess the functionality of the fibrinogen. And if you see the ALT, ALP, so can anyone mention why this patient is liver function tested normal despite patient being a cirrhotic and esophageal varices? That should be abnormal, right? Or not really? Do we have many surgeons here or medics? So if a patient has liver cirrhosis and synthetic function is very poor, prolonged APTT, low fibrinogen, PT, but surprisingly, the patient's liver function is normal. Does it make sense?
Advanced decompensated cells.
Yeah, so there is no liver tissue left for us to release the enzymes. Yes, perfect. The patient had a bit of AKI, they call it. So 6 units of red cell concentrate, 2 FFP, vitamin K given, which is very useful. We still use vitamin K because you are giving the cryoprecipitate fresh frozen plasma for today and tomorrow. You need to stimulate the liver to produce its own factor. So it's always beneficial to give vitamin K if your patient has not got very high risk of thrombosis. We give tranexamic acid in the GI bleed as well. And this patient was receiving Veriplex, which is prothrombin complex concentrate, because andexanet alpha was not available. So the repeat blood is a bit improving, hemoglobin 54, platelet count is 10, INR 5.6, APTT is 68. What do you think is missing here again from the previous case? We've given lots of blood, we have given everything. Fibrinogen was 1. You saw it before. Giving vitamin K, tranexamic acid, PCC. So this is same again. I think we haven't given the cryoprecipitate of 5 million concentrate. So patient got dilutional, further hypocoagulopathy because liver has not produced any clotting factor. And in addition, we have given lots of red cell concentrate, which does not have 5 million concentrate in it. So that's what you see. It's ongoing red cell transfusion. We given 4 pools of platelet cryoprecipitate, which took in Dhaka a few hours to thaw it and produce this. Sometimes it took 24 hours, even in a big corporate hospital, to produce cryoprecipitate, I was told. So you see things are getting better, improvement, platelets improved as well. INR came down quite nicely. What miraculous drugs you have given? Only just cryoprecipitate in addition to blood transfusion. Vitamin K is continuing. So the CT abdomen, obviously, when the patient is bleeding, they did a CT scan. And the problem is, in this patient, one thing I need to highlight to you here, that what is the independent risk factor of developing clot in an inpatient or trauma setting? Because you're producing lots of coagulant, especially in trauma setting, and in a patient who has received multiple transfusion with tranexamic acid, these are the highest risk of getting the venous thromboembolism, including pulmonary emboli. So remember, when a patient has got very coagulopathy, bled, but next the patient had a clot because you have given lots of component and product. In addition, this is a critical illness and the patient is immobile in the hospital. So bleeding yesterday doesn't give protection from a clot or pulmonary embolism the next day. All the developed country has established a very strict thromboprophylaxis protocol when a patient comes to the hospital. When you register a patient, you will not be able to prescribe online medication without doing a thromboprophylaxis risk assessment, we call it. So in balance, you will be putting a risk and balance, whether the patient is at risk of bleeding. If not, then all of your patients should be receiving thromboprophylaxis with enoxaparin or rivaroxaban according to the local trust. No matter what is the underlying condition. If the patient is not bleeding, they are not coagulopathy, all the critical illness admitted patient will receive thromboprophylaxis, which is less prevalent practice in the developing world. And the notion was that our people, Southeast Asian and African, a bit protected from thrombosis, which is basically not true. Actually, that's been proven by ISHG that this is not true. The thrombosis happens globally, irrespective of the race of the patient. We might not know because of the utility of the investigation is not robust. Say a patient is in a rural setting, they won't have access to the D-dimer or the CTPA or even Doppler to understand why the patient had clot or pulmonary emboli and died. They will say probably pneumonia, because if you do a chest X-ray with a pulmonary emboli patient, you will just see a shadow. People will say this is probably pneumonia killed the patient. Actually, these are the patients who die because of the pulmonary embolism. So that's another case for us to remember. 33 years old lady, elective cesarean section, baseline blood was quite good actually, but her APTT was a bit prolonged. But that's been overlooked. That's it's probably a lab phenomenon and error. As you know, in the clotting test, there's lots of pre-analytical and the post-analytical analytical variables can happen in the clotting test system. And we always repeat an abnormal test. And sometimes quite often we repeat it and you see it becomes normal. But in this case, so she started to bleed profusely and they started to give a component which is the red cell, 8 units, FFP, 1 pool of platelets, hemoglobin got better, but APTT is now more prolonged. The factor 8 is less than 0.1. What do you think is going on in patient who was pregnant, had a elective cesarean section, APTT was a bit prolonged, that got overlooked, had a surgery, and then now, post-surgery, patient started bleeding. You did a clotting test rightfully, and the APTT from 49, it went up to 100, and some clever doctor said, okay, let's do a factor 8 assay. It's an intrinsic factor assay, which is very low, less than 0.1. Anybody, any thought? Anything? You thinking von Willebrand disease is causing the FPTT of 100 and factor 8 less than 0.1? How common is von Willebrand disease in pregnancy? It's very uncommon actually. Von Willebrand antigen is again an acute phase reaction, and if you see that goes up mostly. So usually that's not the scenario. And from the FPTT of 49 and is now going up to 100 is very unusual to have this. So she's ongoing bleeding. She started to have more and more blood, cryoprecipitate tranexamic acid, factor 8. 50 units per kg given because the factor 8 is low. So rightfully, doctor said we need to give lots of factors. Was it a right thing, do you think? So emergency hysterectomy performed and ongoing bleeding from multiple sides. She was given factor 8. Was it a right decision to give factor 8, do you think? It was an error, you see, even in a developed country, what I'm talking, because this condition is so rare, despite this multiple infusion. And the doctor said the factor 8 is low and the FPTT is prolonged. We have given factor 8. That's everything right within that. There's nothing wrong. Anybody think of anything? Dr. Rumi, what are you thinking?
There may be something to be done.
So Dr. Rumi is thinking there is an acquired inhibitor cells and an antibody, IgG type of antibody against the factor 8, which is destroying the factor 8 rather than congenital factor 8 deficiency. And this is what we call acquired hemophilia. Not uncommon. We do see, uncommonly we see in post-pregnancy or in pregnancy situation. The commonest cause of acquired hemophilia is about 30% time we know is underlying connective tissue disorder or underlying cancer. 70% time is autoimmune, idiopathic, unknown. This usually happens in elderly population. They come in with SWAS bleed with a very prolonged FPTT, and we have usually low threshold to suspect it. And we check the factor 8, and at the same time, we'll be looking for the inhibitor study to find out why this inhibitor is there, what type of inhibitor. Usually, acquired hemophilia is an IgG antibody against the factor 8 produced by your B lymphocytes in the blood. So the right decision was to communicate with the right team and not to give factor 8. What are you doing? You see, you're giving more factor for the B cell to produce more antibody to destroy more of the factors, and you're creating a vicious cycle. And if your inhibitor titer was 50 and you have given factor 8, tomorrow it will be 100, very strong titer. So we never give factor 8 in this patient. We give bypassing agent, or again, the prothrombin complex concentrated, or for a young patient, we give Novoseven, a bypassing agent. But this patient, because she had the multiple transfusion as well, so we had given, in addition to the activated prothrombin complex concentrated, which is called FIBA, which does not have factor 8, but everything else. So this is, I think we're getting too big, but I wanted to just cover a few of the big things so you will remember in your setting. So 79 years old, made elective coronary bypass graft. At the same time, ABR, atrial valve, aortic valve replacement, baseline blood. You see the hemoglobin, platelets, INR, PTT. So cardiac surgeon in a tertiary, best cardiac center in the United Kingdom. Go ahead to the surgery. Is there a slide missing? Normal bleeding cardiac data. Okay. So obviously when the patient is bleeding, the ongoing, the major hemorrhage protocol initiated, these are the component came in with it. Hemoglobin 39, platelet dropped to 16, PT greater than 60, FPTT is very prolonged. So ongoing red cell transfusion, 4 cryoprecipitate 3 pools of platelets, Novoseven. The one thing for the Rumi to remember is congenital factor 7 deficiency patient receives factor 7, 15 microgram per kg body weight, but the acquired bleeding patient receives, the dose is very high, 90 microgram per kg, and that's very costly, I think. per dose for the per acquired hemophilia is cost us about 35,000 pounds per day. So usually go for the fever for this patient if they are not childbearing. It's very costly business. I don't know. I think it will be cheaper in our country than the UK because where everything is artificially very high. So now the hemoglobin is 101, platelet 85, PTN, PTT, fibrinogen, and the patient is recovering very well. So the timely, if you have not given the cryoprecipitate and right amount of blood, say PEC A, PEC B containing the red cell, cryoprecipitate, fresh frozen plasma, platelets, it is very difficult to keep this patient alive because the bleed in cardiac theater. And have you ever been to the cardiac theater? Any of you? You've been to the cardiac theater to see a patient, bleeding patient? So visit and see what they do, how they monitor the bleeding of this patient. They have a tech machine there to monitor when they perform the cardiac surgeries in patients. So this Rotem and the tech they use. And quite often they are all, you see, the quality control very strictly, external, internal quality control. They've been checked about 10 times every day by the scientists, biomedical scientists, not by the doctors, because we will know how to manage this. So these are the few concluding slides. The NHS in the country where I am living is one of the best transfusion service they've created, and giving wrong blood to wrong patient or a transfusion error is a punishable offense in the United Kingdom. You can be imprisoned if a simple a patient who needs irradiated blood, for example, Hodgkin's lymphoma patient, and we have given non-irradiated blood. It's a crime actually. They keep all the blood is traceable, where the blood is collected, where the process and who receives it, which hospital, which patient, and they keep the record about 50 years for the clarity and safety of the patient's donor and recipient as well. And that's backed by the NHSPD. No patient receive a blood collecting from the blood center coming to the hospital. So all the blood will be collected by the National Health Service blood transfusion system that will be transported to the big facility, the industry in the big facilities. We have 3 or 4 big facilities, and they will be processed. Before the NHS hospitals get blood, you will be held at least red cells 7 days for constant monitoring of the bacterial, microbiological safety, and etc. And the platelets held within, I think, from the collection to the lab to come to the hospital at least 24 to 48 hours because of the microbiological safety, etc. So I think a robust blood transfusion service is so important. And we have now lots of blood component production is coming here, you see. So appropriately using these components in a right patient in a time-dependent manner is so important, rather than just giving a blood transfusion, which can give rise to about 17% of some hospital thalassemia patients who receive blood transfusion now have hepatitis C infection, unfortunately, is very prevalent. So giving the right blood to the right patient is important, not only in the trauma and the major hemorrhage system, in any patient who is receiving blood components. I'll take a couple of questions or comment or discussions, because I know you need to go, because we have already, I think, 1 hour 50 minutes.
So
Please, yeah.
Dr. Nazmul, actually from gastroenterology department. Actually, as we do intervention, and we commonly encountered major bleeding, GI bleeding, sometimes very sharp non-medication. Actually, today's session changed the concept of transfusion. What we did previously. So nowadays practice, we should keep the constant liaison with the hematologist with
only hospital
managing the patient regarding the blood transfusion.
That's very useful, you see, the clinical hematologist. If you have access to one, sometimes you don't have. And you as a physician, gastroenterologist, in your mind, you are more than qualified to act on these bases as they are given multiple units of red cell. The fibrinogen is missing. We need to check, at least check it, and then if you have access to a hematologist now in your hospital, you do have, fortunately, but many hospitals they don't. I was told by the DG Health, both of them actually yesterday, they have created the post for the hematology in 37 medical college hospitals. So both the DG were with us yesterday, education and the Shastra Shiva, and they say created them. There is other plan to get it into the private hospitals as well. Very proactive. So any other comment from Dr. Rumi? Yes, please. Yeah.
Some practical scenario.
Yes.
For regarding this issue, I have some questions.
Please.
You presented this nicely. Please look at it. So for major bleeding, you never say whole blood transfusion. Each and every step you say RCC transfusion, fresh frozen plasma transfusion, cryoprecipitate transfusion. So can you explain why you give component transfusion instead of whole blood?
Yeah.
When we can use whole blood?
The concept of the whole blood transfusion, I think, we know because for decades, centuries, people receiving the whole blood all over the world because we didn't have the machine to do the apheresis or separating that. So we had to do the physically manually. People didn't do it. And there has been lots of study have shown that when you use the whole blood, you produce lots of immunological and non-immunological reaction to the patient, from antibody production to viral bacterial infection. So we kind of moved away for the last 40, 50 years to give the red cell concentrate. But now it's very interesting for the lots of American transfusion medicine, they've invested a huge amount of money there as well. And they have shown if you use the whole blood in the war situation where the patient dying like thousands and thousands, so you don't have time to do the apheresis that separate red cell and others. So if you give the whole blood transfusion, apparently the mortality of this patient can be significantly reduced in trauma situation. So they approved it in their country for the war situation, they would give whole blood. But in the European countries, they won't, even with the war situation, they will, because there are lots of available red cell concentrate.
Enough time to separate the component, that is RCC, fresh frozen blood. So in the case of major bleeding, what should we do? Should we select whole blood or should we select RCC or fat?
Yeah, absolutely. So in your setting, you see, if you think it will be time dependent to separate 4 units of the red cell and you do not have time, then you need to act what you have. You need to keep the patient alive. We sometimes give dangerous drugs to patients. We justify it. Why you have given these drugs to them? Because I haven't done all the testing on this. And I acted to save this human life. And this is one of the situations you will be saying, look, because I do not have time or infrastructure or the patient affordability to get the full red cell concentrate. And all they have is 2 donors and the red cell in front of me to the major bleeding patient here. I will be very happy to say, look, we'll take the risk for immunological reaction later because you can deal with steroid, IVIG and other things. But if you do not transfuse this major GI bleed patient, you're definitely going to die. So nobody should be dying waiting to have the right, perfect components, which is desirable in non-emergency situation. If you don't have it, but in our lab, you see, we have no deficiency. We can give 500 units of blood, and when you transfusing, there will be another 500 units.
Actually, his question was, suppose we have got 1 bag of whole blood, 1 bag of RCC.
Yes, yeah.
And we have patient bleeding. Which one we should give first?
So one of the RCC you have, the red cell concentrate, it doesn't matter. Nobody can say, you see, whether you give RCC first or whole blood. There is no study in the world.
Actually,
but you give anything, you see, whatever is available first, you give it, you give the whole blood later. Giving the whole blood first or RCC later is not going to affect anything. You can give anything, what you have in front.
The question is, a patient is going to have a cesarean section.
Right.
The doctor is saying to the patient that, or the doctors, that you keep ready 4 units of blood.
Right.
So they will prepare 4 units of whole blood or 4 units of RCC.
If you can.
That is the question.
Yeah, sure. So if you can get the 4 units of RCC, if you have enough time, you do the RCC.
Yes. So in selective cases,
in between these two, is there any role of platelet? Suppose
So as we said, I think if you are giving the by rule 4 units of the red cell and when you initiate 5 units, then you should be giving a pool of platelets as well. Otherwise, the patient will have dilution. If you give RCC, then you give platelets because on the red cell concentrate, you have very few drops of platelets, few number of platelets. But if you give the whole blood, that has fresh blood, you see. It's not have 7 days in the lab. So they have lots of platelets in it. And that is also,
Sometimes this may.
yeah, absolutely. You see, the resource is the constrained situation or war situation. They have shown it because of this fresh blood, whole blood has got lots of factor in it, as well as fresh platelets. You know, it's a healthy platelet. So
Actually, what you do in road traffic accidents?
the road traffic accident in the United Kingdom, the RCC, red cell
RCC,
concentrate. We use it.
Sir, I
Red cell concentrate. Because they have lots of factors with it, as we cryoprecipitated, they will have readily available what they need. There is no time issue. Availability is all there. But we are unfortunate here it's a very costly business. Their population is 60 million, 6 crores, a rich country there, but we have a large population.
So the case of advanced liver disease, which is having the major patient. So what should be the actual protocol? What should be the ratio of transfusion? RCC, then
If you go to these slides, the major hemorrhage should be in the if you see the definition of it, if you think your patient is having the definition of the major hemorrhage is like this.
yes, more than 40%.
So if you think a patient is, sometimes it's difficult, you're not quantifying rightly. You thinking in front of you, a patient is massively bleeding. You initiate rather than calculating and waiting for it. There is no harm to say, oh, my patient is bleeding profusely and it anticipated a major hemorrhage. And you initiate major hemorrhage. You can always stop it. You do not need to continue. Once the bleeding is stopped, you're not going to pour in blood. So you can stop there. So these are the stuff.
One thing I just want to know whether a patient is losing blood, a lot of blood, and we are giving RCC or
Whole blood.
whatever. What are the points we should keep it in our mind? Suppose after 4 bag, 3 bag, what are the things we should check and what are the things we should
So you're
keep?
checking the vital, obviously, patient, but that one thing is very important.
Biochemically, what things?
At least every 2 hours or couple of hours do the clotting test. That's the only NFBC, a CBC we call it. That's the only way you will be knowing actually what is happening inside the patient's biology. So checking the clotting is so important. Otherwise, you don't know. You're keeping lots of products. By
Calcium or anything?
the calcium you're checking as well, because there will be dilution a lot of calcium. I think on the slides, I probably missed it. There is a slide there as well. I think on there you will be check because the patient calcium goes down, and you will be giving most of this patient calcium like 2.05. It goes down, and there is no harm to the correct. And all the if you see these slides, I think it has got calcium in it. You see it, and when you should be giving calcium, etc.
I want to add. Our conception is like that. Fresh blood transfusion means transfusion within 24 hours of collection.
Yeah.
But platelet viability needs 22 degrees centigrade. So after collection, if we preserve it into the normal freeze, that is 2 to 8 degrees centigrade, I think platelet viability will not persist. Right. So our thinking or our perception is not the correct. Fresh blood means without preservation, we have to keep preserved in 22 degrees, but it is not possible. Without preservation, we have to keep if we want to increase the platelet. Otherwise, platelet may destroy.
Yeah, you will because to keep the platelets alive, you have to put it in an aggregator. You probably have seen it just moves it, keeps it active. Otherwise, it dies very quickly. And if you put it in the fridge, it will definitely die.
Another issue we have to face sometimes, that is for surgery, surgical department, anesthesia, and hematological view, there is little bit different. One example that during surgery, surgeon thinking that bleeding may be 200 ml or 500 ml. We know that 200 ml or 500 ml may reduce the hemoglobin 1 to 2 grams from the baseline. So if a patient came with a hemoglobin 10 grams per deciliter, so 500 ml bleeding without cardiac issue give the argument result of 8 gram per deciliter after bleeding. So this hemoglobin also stay within safety range. So there are some two issues that restrictive type of blood transfusion and liberal.
Correct.
So most of the cases current recommendation is a restrictive transfusion, that is 7 to 8 hemoglobin is enough. But the main thing, anesthesia not agreed with this. But this guideline published with the whole consensus of surgical department, anesthesia department. So if we fail to reach a common goal, then surgical department view different, hematology view different, anesthesia view different. Ultimately, patient survival sufferings increasing.
Yeah. This is a very common scenario is what he described. It's not only in our country, you see, even in the Western world, but the country where I am, the anesthetist comes in and say, we, before the knee hip replacement, we want to see the hemoglobin 11.5. A patient is got CKD and she's 90 years old. How are you going to get the hemoglobin? So you end up giving you the erythropoietin and the checking the iron, and if the ferritin is less than 300, you end up giving some IV inject as well. And that happens not infrequently in the Western world as well. Because you have to see an anesthetist is scared because he's seeing in front of him, somebody will bleed and hemoglobin drop is the elderly lady, 87 or 90 years old. She might not have proven cardiac problem, but she might have when the hemoglobin drops to 6 and 7. So you can see the anxiety there as well. So that's we understand as well. And from a patient's perspective, it's very frustrating. Elderly ladies or the man, they say, it's a population is very aging. You see, in our clinic, is 80% patient is above 85. Okay, very rarely you see a young patient unless they're unfortunate. And they're waiting for hip replacement for years. The hemoglobin is not coming up and they can't have operation. Other routine operation as well. But emergency operation obviously will
So
be
in this
supported.
scenario, what should be the rational approach?
The rational approach for this to resolve it, you see, we need to say that hemoglobin probably 10 and above as baseline for the patient who is known anemic for. Obviously, we need to evaluate the cause of the anemia. We need to know why the patient is anemic. And if we know this is an anemia of chronic disease, the patient has got renal failure and other cause, and baseline hemoglobin is 10, we probably have a strategy to say, what is the expected blood loss for this operation? Do we need to really improve the hemoglobin by giving erythropoietin or the pharyngeal or Benufar, whatever available, pre-surgery if it is routine and they improve the hemoglobin a bit? Or are we okay to go ahead surgery, expected blood loss 1 liter or 500 mils? And in case of the patient excessively bleeding, we have a strategy to get the blood ready for transfusion. So that should be the approach. And this is what we do as well. Convincing anesthetic sometimes is difficult as well.
Several referred from, especially from dental surgery. That is hemoglobin 8, and proposed surgery bleeding may not cost more than 100 ml. Only within 100 ml you can perform this surgery. But they think that this hemoglobin not satisfactory. I examine the patient, take history, clinically totally sound. Then I just told you, you can do your procedure without any hesitation, no need of further transfusion. Iron deficiency, it will take 1 month. But if you have urgency, you can do surgery safely now. If you have no urgency, you can wait 1 month, then you correct the hemoglobin. You will see that will be within this time. But still now we cannot convince or satisfy ourselves.
But this is again, it's not uncommon, you see, because of the dental surgeon is very scared if the patient stuff, because they sometimes see the patient pour blood. And 8 hemoglobin is very scary thing. And where is he going to get the blood if the hemoglobin drops to 6? Because we don't have an NHS blood lab there, is he to just pick up the send a porter and he will get pack A, pack B. Because you need to call the relative coming from probably Srimangal or from Kumilla. So you can understand, I think I see lots of practical aspects which is making our mind.
Another experience you share with your colleagues, the transfusion of non-relative blood transfusion is mandatory to avoid the relative transfusion. Is very important to develop the graft-versus-host disease. This is a common interest of our patient to give their father's or parents' blood transfusion, or his son or daughter is a very grave condition. So we must expect this message your colleagues and other patients. Yeah.
For last 2 or 3 months, we strictly maintaining our protocol, the pre-transfusion history completion. So in that situation, we just advise them not to give fast degradative blood. Any rare blood group or crisis moment, then we just observe these rules. Otherwise, we strictly follow the fast degradative no blood transfusion.
So what both Professor Kabir from Bangabandhu Sheikh Mujibur, I think we didn't introduce yourself here. So it's,
Oh, sorry.
Professor Amin Lutful Kabir from Bangabandhu Sheikh Mujibur Medical Center, is the teacher of both of these hematologists here. We work very closely with various initiatives in our country. Indeed, he's the convener, he was the convener yesterday for the hematology conference, international conference yesterday. So what they are saying is a common practice is getting the related blood, because we will bring our 5, 6 brother sisters to get the match and get the blood transfusion. This is what we have seen all the time. But related blood is not advocated worldwide. The only reason is the graft transfusion associated, there is a small risk of transfusion associated graft versus host disease. Because if I receive my brother's blood, ABO matched blood, RHD matched, but his lymphocyte, T lymphocyte will be slightly different than me, my brother's. So initially my body will say, your brother's blood perfectly match with you. So you will take all the blood to my body, including the T and B cell, whatever will be circulation. And the T cell will find their way to go to our liver, skin, eyes, and everywhere. And then they say, no, he's not exactly me, he's slightly different. Then they will start producing their response called transfusion-associated graft versus host disease. And why this is important to tell our patients and relatives that if patient is unfortunate and graft versus host disease, transfusion-associated graft versus host disease starts, mortality is 100%. We keep them alive. There's no medicine to treat them. But why? So you might say that for the last 500 years, people are receiving their own brother, sister's blood, and they are not having transfusions to the graft versus host disease. Why? So that there is an explanation. So we don't want to kill anyone. You see, this is the idea, and this is the notion that we should not be receiving the brothers or related blood. But in an emergency, we take the risk. Even in Western countries, when a patient comes in major trauma situation and we need irradiated blood, there's no irradiated blood, we give whole blood. So we will deal with the problem later. He might not get transfusion-associated graft versus host disease, but keeping him alive, the transfusion-associated graft versus host disease risk will be 0.5%. But if I do not transfuse him, non-irradiated blood, his death will be 100%. So you see, risk can balance between, you see, harm and not to harm.
And another question to Rumi, if a patient, a young girl, 14 years, came to me is 4 grams of hemoglobin, is later diagnosis as iron deficiency, and how will treat this case?
So that will be more important for the medical doctors.
Dr. Rumi will answer in this.
Well, we can ask one of the medical doctor. I think are you all of the professors or you have registrars? Registrars, assistant
No.
medical officer,
Or assistant professor and above.
or assistant professor level. Any medicine, internal medicine, anybody you can, because you will be seeing more of this. Yeah, please, yeah. You give iron transfusion.
To identify the source of loss or source of deficiency.
Okay.
At first, identify the cause.
No, no, he said that is 14 years, 14 years. gone.
14 years, is there iron deficiency, will transfuse or not?
If the iron,
If it is a diagnosis case of iron deficiency anemia due to the less intake or there is an increase of menorrhagia, how will treat the case?
having hemoglobin levels
It's 4 grams.
4 grams. Should initiate the RCC.
So that's, I think, it's a bit debatable. It's a bit young people, by this time, their hemoglobin is 40. It's probably happened over 2 years. It doesn't happen overnight because it's a slow gradual. And many of these patients, they're quite asymptomatic. They said, I feel a bit tired and lethargic. And somebody said, okay, you look a bit pale, do an FPC and CBC, and then you find hemoglobin is 4, ferritin is 2. So
If
For
the
young
patient
people, you-
is symptomatic, tiredness, weakness, breathing difficulties,
still,
that is still we wait.
no, still you see, if you're a young patient, 14 or 20 years old, they're quite compensated, they're strong, they don't need transfusion because transfusion will die, you see, quickly. So what
Actually,
you
that is
give
the
is-
last several months is 14 years girl. He just increased after 3 weeks is 7 hemoglobin 3 gram by taking his iron and just food, nothing else. And another girl is present at 6.5. One of the gynecologists is asked to give 4 units of transfusion. I don't give any transfusion and patient recover. And
But it will
transfusion
take
is-
time.
No,
Recover by oral or parental.
is in these cases, we should give the parental transfusion. If there is a hurry, as patient is active, so we can give parental. This is my practice usually. If patient is hurry, he needs post transfusion, we avoid the transfusion.
And at the same time, we should identify the cause and treat the
Of
cause.
course, it's very important. Women's bleeding is very important. Is another message to Rumi, another colleague, is a, we don't know, many of our women's are bleed. At least 3 days bleeding, sometimes bleeds, 1 day is second day or third day is more bleeding. We cannot identify. This chronic blood loss ultimately, by the years together, they come down the hemoglobin. So in this, most common women bleeding is menorrhagia is other unhidden, a many cause of factor deficiency or latent deficiency. It's not, we can explore the
So
situation.
the concept has been changed
Yes.
a lot and we should
The approach should be
very careful
conservative.
about
Yeah.
transmission.
Of course.
Yeah, it's only you see, because transfusion has got lots of ways. from
Another
viral
transmission is, I can say, is pregnancy is very important. Transmission is come down to dilation, anemia, sometimes deficiency anemia, hemoglobin come down to 8 grams. Or the obstetrician goes transfuse blood. So in these cases, we used to avoid transfusion before 28 week pregnancy. Because there is a chance of develop the antibody and their fetal loss is chance. So we should avoid the transfusion before 28 of weeks of pregnancy.
Sir, I have a question here. If the patient is symptomatic, as your patient is 14 years.
No, patient is not symptomatic.
If no symptom, then.
No transfusion.
No.
Basic
I think,
mechanism is
let
that
me just clarify
if
one thing.
symptomatic, Then we'll transfuse.
This
and
is-
other not.
This is,
In addition, I would just want to one thing that if you know that have the female patient have menorrhagia, in each cycle, they lost around, normally 30 to 80 milligram of iron per cycle. Yes, so if our female patient who is not taking iron for his food, so he may be he may be anemic in 4 to 6 months. And this is the basic mechanism of our enemy in our country female. I have a question to Dr. Amin Islam. So, in a patient who is basically massive hemorrhage, and you know that in our country, all for patients who have done his blood grouping in a nice situation where grouping is not possible, and he have to do a surgery. And what will our colleague do?
so it's a massive transfusion in a few trauma situations. A patient brings in from the street. Nobody knows what is his blood group. You need to transfuse, so you transfuse O negative blood. Okay, universal. But now we kind of, because of the shortage of the O negative, if the patient is not childbearing and the male, then we transfuse O positive blood as well. So it should be a.
That's what one request to all. So
Please do not wait for the blood group. If your patient, you don't know the blood group and bleeding in front of you, keep the O positive or negative blood, what is available.
if we subsequently place, if you find that there is anemia, that we need to transfuse. So from myself, special request. Before transfusion, please collect adequate sample to identify the underlying cause. So if you transfuse and then try to collect sample for identify the cause, this will give misleading result. So before transfusion, you must collect some sample for the most possible cause of.
There was a case, I think, Rumi presented from this room. The patient was had multiple transfusion over 7 or 8 years. And then eventually the patient had hemoglobin electrophoresis, and they said patient hemoglobin E trait. What was the reason for it? Because parents does not have trait. So the patient cannot have it. So why your patient was hemoglobin E 25%? Because it was you testing on a blood with somebody else's blood who has hemoglobin E disorder. So to remember, take the baseline sample because you are not going to get serum ferritin B12 and folate level on a transfused blood because you will get a patient transfused blood, the results, not the patient himself. So take the blood or ask the lab to add on retrospectively. I have given the transfusion for such a reason. For the sample you have, can you add on B12 folate and ferritin? So taking a bit more blood is not harmful. The patient might say, "You've taken lots of blood from me, made me anemic." It's a quite loss. But say, don't worry, because your body will produce this within minutes if you drink lots of water. Yes, please. So I think we should now, because it's the working day, sir, conclude, please.
আমার একটা কোশ্চেন ডক্টর শহীদুল ইসলাম প্রফেসর অফ অ্যানাস্থেসিয়া in case of severe bleeding what is the role of colloid or crystalloid can you use it
Yeah, so there are lots of study they have done is what is the best fluid for the major hemorrhage. Should we be giving colloid or crystalloid? So I remember when I was in a trauma emergency doctor in Royal London Hospital, we used to give lots of colloids and apparently that's been detrimental in ITU setting. So they now select fluid very carefully and you can use either. They use usually the crystalloids fluids nowadays. That's what I have not read for the last 6 months what happens, but we need to check it and I'll probably can feed back to you what is the current practice in major hemorrhage, which the fluid they use in right setting. I will let you know. I'm not updated for last 6 months. But I remember in my time, in 2006 and 7, when I was a trauma doctor, they used colloids in hypertensive patients. And I remember squeezing the colloids to these patients.
first line colloid then crystalloid
That's what they used to do colloid. But apparently, retrospectively, when these patients were ventilated in ITU, there was some detrimental effect on the patient who received colloids in emergency. So I need to check what was the outcome of this study and what are they using. My understanding is now they're using crystalloid, not colloid. Because colloid increase the blood pressure immediately, but later on that might be detrimental because you will be leaking immediately after. So I need to see that one. We have any critical care anesthesia? I think. If there is
No, he's
anyone
the
from-
professor of anesthesia.
Oh, you are the anesthesia.
Critical care is
Yes, Dr.
the-
use crystalloid first
You are using it, so that will be, I think this is what I think that they changed it, but in 2006-7, they used lots of colloids to temporarily increase the blood pressure and things. And that was harmful for the patient, they say, so they're now using crystalloid, so we got the answer. Thank you. Thank you very much, sir.
Sir,
Yeah, please, yeah.
Sir, you say something about the auto transfusion. If there is hemoglobin is normal, with 14 and patient will have this comorbidity, is it wise to use auto transfusion before surgically 1 or 2 units of
You mean autologous blood during the cell salvage, you see, when you're doing the surgery, you
also, but we collect from patient blood.
auto, so you collect the patient blood,
Prior
Yeah.
procedure.
you keep it in the fridge, and then if the patient bleed, give his
After
own.
surgery, we can transfer the patient. Take 1 or 2 units of blood.
Yeah, I don't know because I have not been exposed to this practice, you see, collecting patient because of the availability of blood where I was treated, but
If hemoglobin is normal or more than 14 and patient has no
Usually it's over
comorbidity, patient is.
yeah.
Because we face the transfusion, we have the surgeon, we face always face this problem.
So I understand now you're saying because of the availability from the donor blood, so if the patient is well and I'm expecting he might bleed, is it wise to collect his own blood, wait a couple of weeks so he becomes normal hemoglobin, and then in case he runs into trouble, then you transfuse his own blood? This is a good thought, but I have not known about this practice, you see. So it's possible. I don't see any harm in it, this patient's own blood, because
Especially
you know
blood-
Jehovah's
Blood
Witness.
group is rare, maybe negative.
Yeah, that's very good. Jehovah's Witness, several things, as you know, they will not have transfusion from anybody, and they will not have even their own blood if you take it out, as you know. But this is what you said, I think in rare blood group or in the situation where they don't have any relatives, they can't buy any medicine, the blood, then, or donor, for example, then it's a good idea. And if you said he might bleed excessively, but if you anticipate blood loss, say 1 or 2 liters, it's fine because next few days he will regenerate his own blood because he's young and healthy. It doesn't take, because every second you're producing billions of blood cells in your body.
So with this technique, default transfusion, 1 month ago planned surgery, rare blood group, no donor. You can collect everyone 1 bag. Gradually, you can give the supplement to the patient, and if no further issue, each week patient usually recover 1 gram of hemoglobin. So you collect 1 unit, that is 1 gram deficit, and give 1 week space, then this patient will develop recover 1 gram. Then next week you collect 2 units of blood and reinfuse the previous one. So this is the stepwise protocol. At the end of 1 month, you can collect 4 units of blood. But this is actually theoretical. Still now, I have not faced this type of process.
You might actually, it's a very good question. Eye-opening for me. Yeah.
So
Really good.
we should conclude, sir.
Yeah, please, please.
Thanks to the audience for being with us for this period of time. We're very much thankful to our dignitary guests, especially the speaker, Dr. Amin Islam, and also Professor Amin sir, for giving their valuable time. We have learned so much from them. Now, I request our Honorable DIHS Lead and Director General of this institute, Professor Dr. Fazlur Rahman sir, to conclude the session, and then I think I will hand over the letter for the honorary professorship of Professor Amin Islam sir, and then hand over some token gifts as a token of honor to our respective guests. Sir.
So I again thank Professor Amin Islam and also Professor Kovid to come down here and in this morning and enlighten us with this sort of knowledge. And what I could perceive that what he said that we must, the clinician should differentiate that whether the patient is life-threatening or not. If the patient is a life-threatening problem, then he can transfuse whole blood, or otherwise he should separate the components, etc. Another thing which we lack very much, possibly Professor Kovid has got this sort of situations, but we even now we cannot produce the these factors, especially the fibrinogen, who is emphasized very much. And what I can say that we are a low resource organization, but still we have a plan. We are searching for donor that to enrich our lab, enrich our blood transfusion department, that we can be able to synthesize this sort of factors like fibrinogen or factor 8 or something like that. This is our a plan within our mind. We have discussed 1 or 2 times with some party. It was the Rotary Club, no?
Yes.
It was we had a meeting with Rotary Club, and they were they showed interest to set up a center like this, and we are having whether we can do it or not, but we hope that as because we have taken it into our account to enrich our transfusion department to synthesize this fibrinogen or factor 8 or something like that. So in there, one day definitely we'll be able to do it. So with this, again, I thank everybody of you that you have given time in this morning. And now I am handing over the letter of this honorary letter of honorary visiting professorship to Professor Amin Islam. We have given it to him through email. Now I am handing over the hard copy of the letter. And our national professor, A.K. Azad Khan, he took the initiative, and he and our Secretary General Badas they have all desire to do this. So I am doing this in their favor. Thank you. Thank you very much.
আইসিইউতে 4 জন 5 জন
Thank you.
So a few days back, on 2nd of November, we celebrated our 17th Foundation Day. We just hand over the token of love to them.
Thank you.
Memento of the 17th Foundation Day of BI. Yes. Thank you so much.
Thank you. It's a pleasure.
So with this, I thank everybody and especially to Professor Amin Islam and Professor Covid and also to Dr. Nazmul. So with this, we conclude here. Thank
I
you.
enjoyed the session as well. Yeah, I'm sure that we will meet again. Assalamu alaikum.